So in terms of radiation options for a patient newly diagnosed with prostate cancer, and we presume that the cancer is confined to the prostate, we have an option called intensity-modulated radiation therapy. Nowadays that's called image-guided brachytherapy in the form of low-dose seeds. Less commonly in Cincinnati is something called high-dose brachytherapy. Some men get a little bit of both, IMRT and sources placed into the prostate, Cyberknife, and protons we can talk a little bit about as well. Prostate cancer patients are often stratified into risk groups as to how likely the cancer is to be confined to the prostate, how likely it is to be indolent versus aggressive, and that often dictates if seeds alone is an option, if you need a little bit of both, hormonal treatment, if there's a likelihood that surgery isn't going to quote-unquote get it all. Some of these terms might be common to some of you, but Gleason score, PSA, how many cores are positive, that helps sort of dictate how we look at treatment in terms of what options should be pursued. So the rationale for IMRT, which is external radiation, rectal and bladder toxicity limit the total radiation dose that can be prescribed. When I moved here about 20 years ago, somebody explained to me if I could give you 100 radiation treatments to cure a cancer on your leg, but your leg would fall off, that might not be so wise. So ultimately, what else is getting hit, determine when you say enough is enough. IMRT uses a device called a multi-leaf collimator and computer technology to modulate the intensity of radiation. This MLC device has metal leaves, and I'll show you a picture here that moves in and out of the field while the beam is on, and you create different areas of intensity. So if this is a patient, after consultation and some introspection, says, "Doc, I think this IMRT stuff is for me," they come to the office and have a CT scan. Every 3 millimeters, we get an image through the pelvis. We then draw the other organs that we would like to avoid. We're not too smart in radiation, so we make the bladder yellow and the bowel brown. And we make the prostate red, thinking that sounds important, like a stop sign or a traffic light. And the circle around the prostate, in another shade of red, is sort of a margin for microscopic spread, a little uncertainty each day in how you'll set up for the treatment. But we get a CT scan here. And then somebody figures out how to best aim radiation at the prostate, which their day job is called, they're a dosimetrist, and radiation is aimed from multiple directions. From this direction, this oblique angle, from this direction, sort of all meeting in the middle. So where the dose meets is the high dose area, but potentially if you aim from 10 different directions, 1/10 is only coming through this area, so the skin and the soft tissue shouldn't get too much radiation, 1/10 from this direction, etc. So the CT scan tells us where to hit from some of these different directions. Again, yellow is the bladder, we'd like to avoid that, the bowel's in the back. And you can see here, for example, much of the bowel is out of the way, much of the bladder is out of the way, but from all these directions, we're hitting what we want to hit. This is what a linear accelerator looks like. Patient's lying on their back, the head is lying in this little neck support headrest here, and the radiation is emitted out of the machine at the head of the machine here. Notice that the table rotates in multiple different directions, as does the machine around something called a gantry. This is what the MLC or multi-leaf collimator looks like in the head of the machine. And these are the little metal leaves that sort of move in and out and sort of shield different areas of radiation more than others. And I got a nice little, let's hope this works. So the radiation machines make radiation in sort of squares or rectangles. So imagine this is where the radiation is being emitted by the machine, but this device can sort of modulate the radiation that's being emitted in this rectangle. So these metal leaves move while the beam is on, much like film, where the light hits the film, it's going to be dark. Where the film hits something, that's the image. If you put a film on the other side of this particular multi-leaf collimator pattern, you can get a picture, and lo and behold, you get a picture of Ben Franklin, which might not be Alexander Hamilton, apparently, in the not-too-distant future. So where the film is dark means the radiation was on a whole lot. Where the radiation was a little modulated more, that's a little lighter area. So if you aim radiation up from these multiple different directions, much like a topographic map, the high dose area is concentrated right around the prostate, less and less is hitting, in this particular slice, the bowel in the back, the pelvic bones, and soft tissue around the prostate. So in my line of work, we focus on occasion something called the therapeutic ratio, the likelihood of doing good versus doing bad. Well, one way that you can do good is to avoid the bladder and bowel with IMRT, but one of the other advantages that we now use in conventional treatment is actually imaging each day before the machine is turned on. Not only am I more confident knowing I'm missing what I'm supposed to miss, but success of treatment should correlate with are you actually hitting what you're aiming at. And things do move a little bit each day depending on breakfast, lunch, and dinner. So there's different ways to image each day. Some centers used ultrasound in the past. Sometimes there's these little gold markers put in, gold being a very dense metal, readily seen on x-rays. There's a system called Calypso, and many centers actually get a very cursory CT scan we call a cone beam CT to help you localize each day to know, yes, I'm hitting the prostate, so treatment should work here. And then somebody smart said, well, if we're now giving less side effects, what if we push the dose higher? What will happen? There was an article published in 2013 out of Sloan Kettering looking at success in 1,000 men treated with IMRT to what's called 86.4 gray, or that's 48 treatments. Sometimes that gets a little bit prohibitive for people when I say, we started treatment when the grass was coming out of the ground and we should finish when you're raking leaves. Some people find that a little bit burdensome. But they followed people for 5 years, and again, I know it was several slides ago, but they said that this dose worked great. If you had Gleason 6, your PSA is under 10, worked pretty good if your PSA was 10 to 20, Gleason 7, and not perfect, but not 50-50 either if your cancer is a little more advanced, albeit localized. So IMRT over the last 10 to 15 years suggests better tumor control with higher doses. Contemporary treatment can involve as many as 48 visits Monday through Friday, recognizing even a few days are missed for holidays, snow, machine needs a service call, etc. But when I started practice about 16 years ago, I inherited someone named Pearl Compan's practice and follow a few men still that she treated. But the doses we give now are about 25 to 35% of what people got in the 1980s and 1990s. So it's hoped that people do better. Again, we're more confident we're off what doesn't need to be hit, the adjacent bladder and bowel, and more confident we're hitting the target each day. So going from one extreme of IMRT, 48 treatments, we'll sort of go to the other extreme and at least talk about brachytherapy. Brachytherapy is a single day outpatient procedure. There's no sutures. You're under anesthesia, general anesthesia typically for 60 to 90 minutes. Hopefully there's no urologist in the room, but some argue that maybe the side effect profile is a little better than surgery, that leaking is not particularly common, and if sexual issues arise, which can happen for sure, it's in the future, and some men who have surgery, sexual function never recovers, whereas men get older, if we're going to lose that behavior anyway, why not kick the can down the road? I used to never say that 15 years ago. It's a real rude awakening. So low-dose rate brachytherapy is permanent insertion of little radioactive sources into the prostate under general anesthesia. And I got some gruesome pictures. It uses transrectal ultrasound to accurately deposit the seeds into the prostate. Typically, a man is poked in the perineal region with about 15 to 25 needles. And typically, at least in the world of iodine seeds, you go home with about 70 to 110 seeds. How many seeds you get is not a function of the PSA, it's not a function of the Gleason. It's how big is your prostate and how many seeds need to go in there to make a nice sphere of radiation that hugs the gland. Some people get a little bit of both. I think that was one of the questions for me to answer later. Some people just get seeds. The ideal patient for seeds is typically what we call low-risk disease, PSA under 10. Gleason 6 only because 7 and higher portend a little risk of spread beyond the prostate, and seeds don't put much of a margin around the gland. And one of the issues though with seeds is the entire prostate is hit, and the bigger the prostate, the more of it grows behind the pubic bone, and it's hard to put seeds in the entire prostate the bigger the gland. So compared to IMRT Monday through Friday for weeks and weeks, the prostate's kind of still because somebody's asleep under anesthesia. The seeds only treat a few millimeters, so a little less radiation is delivered to the bowel compared to external radiation. Certainly convenient. Patients go home the same day, and again, some sexual side effects are kicked down the road. Disadvantages, because there's side effects to everything I do. The acute urinary side effect profile can be a bit prohibitive. I sometimes joke with people, if you're up 6 times a night and know where the bathroom is at Target, Walgreens, and the Speedway up the road, seeds are not going to be very gentle to you. That it's hard to get up more than 5 or 6 times. There's medicines for burning, there's medicines for slowing, but some of these issues patients can complain about for 4 to 8 months, and even though, my gosh, the procedure was done in 90 minutes, a patient might be feeling side effects for a while. Again, gland size is an issue, whether you get seeds by themselves or seeds with external radiation. And seeds involve anesthesia and a little bit of bleeding. So sometimes people on Coumadin, that's a little bit of a hassle getting off the Coumadin. If you're supplemental oxygen for bad emphysema, you're under anesthesia for 90 minutes. Sometimes, if there's other ways to treat the prostate without incurring some of these risks, people pursue another modality than seeds. So this might be a little grainy. So a patient is put to sleep. The ultrasound is put in one's bottom, and the first 15 to 25 minutes is spent just doing the planning. Where the heck are the seeds going to go? The ultrasound probe is in one's bottom, and we'll get to better pictures than this. On ultrasound, everything's black and white, but somebody decided that this was the outline of the prostate capsule or lining. This would be the urethra running right through the middle of the prostate, draining the bladder. I think these are some calcifications that are sometimes seen in the prostate. But one takes serial images through the prostate every 5 millimeters and imports those images into a computer, and then sort of goes through a dry run. That if this is the bowel in the back, and this is the urethra, and one puts these little sources in these locations, and you do this every 5 millimeters from the top of the prostate towards one's chin to the bottom of the prostate towards 1 feet, and these little radioactive sources are these little green dots. Again, the prostate's in red, but you throw 70 to 110 seeds in the prostate, and here's your gland, and you're treating this dose of radiation in green that's basically hugging the gland very tightly and minimizing the bowel in the back and the bladder above. I think this is the next picture. Okay, so these seeds are very, very small, about 4 to 5 millimeters and 1 millimeter in diameter. They wind up in the prostate through needles that are about 7 or 8 inches long. I think, much like after dental work I had, I knew why they invented anesthesia. I think this is another reason. But seeds are put into a man's bottom through their perineum. And this isn't always, this is the reality of the day job. Ultrasound probe is in one's bottom. Perineal region is cleaned and sterilized, and this grid helps guide the seeds. Then again, if you go back to the ultrasound, page up, maybe we'll get us to the previous slide. Well, you can see on this axis we have numbers, on this axis we have letters. And on ultrasound, this is real time, the seeds are placed. So on this particular patient, again, this is the prostate, that's the urethra, and hypothetically we want a seed here at E, what do we call this, 3 3/3. This grid is used to help put the seeds in the prostate, and lo and behold, E and 3 3/4, we got a seed there. And there's a seed here, and here, and here, and here, and in aggregate, multiple seeds are put in the prostate that if one gets an x-ray after the procedure, this is someone's pelvis, you can see all these little pellets in there. There are no stitches, you go home the same day, but there's some bruising to the perineal region, the urine can sting and burn starting a couple weeks after the procedure. There can be a little blood in the urine. but this has definitely been done on tens of thousands of men with decades of follow-up, like IMRT. Everybody knows the good, the bad. Seeds are an option. Some people get a little bit of both. So if the extreme for external radiation is 48 treatments, what if you do 25 treatments with IMRT that treats a little more broadly around the prostate, might rein in any microscopic disease beyond the lining, and then take a little break, take that trip out of town you couldn't do during this 25 treatment, and then put some seeds in. When you're seeded in this setting, you get less seeds, and they're a little less radioactive because you quote-unquote get credit for time served. But gland size and baseline urinary habits still remain considerations that if you're up every hour on the hour, and seeds aren't going to be your friendly. But Sloan Kettering looked at patients, again, they're a big IMRT center, to 86.4, and they said, well, what if you do a little bit of both? You know, what happens? These were on intermediate risk patients, so again, got Gleason 7 is probably the main driver of what makes somebody intermediate risk. You know, some people had a PSA north of 10, that would be another risk factor. But the combination treatment has a little bit higher likelihood of the PSA staying suppressed 6, 7, 8, 9 years later. So you get a little more radiation to the prostate if you do a little bit of both than going full bore for 48 treatments. And it's a little more convenient too, that you're only asking somebody to come in for 5 to 6 weeks than close to 10 weeks. There's a little more side effect profile because despite more radiation treating the cancer, which is therapeutic, there's a little more exposure to the bottom of the bladder from all the radiation. Sometimes there's a little higher risk of a rare drop of blood in the urine or bowel as an after effect of all the radiation to the prostate, even if it's aimed awfully precisely in 2016. And in my line of work, there's these scales of side effects that, for example, let's go to the bladder side effects. If you occasionally have a little blood in the urine or need a blood transfusion every now and then, that would be considered grade 2. Grade 3 is ratcheting it up a bit more. You need narcotics. You're getting up more than once an hour, sometimes needing surgery. That's a grade 4 side effect. Those are not expected by any means, but unfortunately, they do happen. So this particular author from Memorial Sloan Kettering in New York concluded the enhanced dose with both IMRT and putting in radioactive sources leads to superior PSA outcomes, but you get a little more toxicity, which is not shocking. In terms of high dose rate brachytherapy, that might have been one of the questions from somebody here in the audience. I'm not an expert in HDR. It's sometimes used alone or with external beam radiation. Typically involves 2 to 6 treatments, although people keep giving less and less. But from my reading, 1 6-treatment regimen gave 3 treatments in 24 hours, and that whole endeavor was done 4 weeks later. So a patient's not radioactive, that's advantageous for some people. If there's a pregnant person in their life or grandkids, some postulate that if you give a big dose per treatment rather than baby doses for 9 or 10 weeks, for a slower growing disease like prostate cancer compared to a lung cancer, that may be more therapeutic. And one of the things with HDR, if there's an MRI ahead of time and you see a definite spot in the prostate, maybe you can hit that a little harder. But give a little more dose.
Can you go back there for 1 second about the focal treatments? Your last bullet.
Yeah. Whoops. So what may be the future of prostate cancer is not necessarily removing it or treating the whole prostate, but if there is one area and only one area, just treating that part of the prostate. I guess in this setting though, that if you treat, most conventional treatment treats the whole prostate. You know, as I tell people, sometimes prostate biopsies, they're not blind, but when a woman has breast cancer, the patient or the mammogram says, yo, there, please, put the needle. When the PSA is a little high, if my hand is cancer, the urologist misses, hit, misses, hit, misses. They don't always catch what they're looking for. That's being explored further with MRIs and more targeted biopsies. But if you do see a lesion and you are awfully confident that is the only lesion, the future might be just to treat the spot, not the whole organ. But one of the things people that do HDR say, well, if you know there's a spot in the middle of the left, maybe you'll give that an extra 30% of the radiation and give it a little extra dose, and that may be therapeutic.
But that's not standard of care, that's something in the future.
Pardon?
That's not standard of care today, people aren't doing it.
Focal treatment, not that I'm aware of in Cincinnati, but I'm not aware. So this is a little more gruesome picture. So we still have a grid in one's perineum, gentlemen sitting on their back and their legs up. These catheters that are a lot like the needles I showed in a prior picture, those are put into the prostate under anesthesia. Patient then gets some imaging, typically a CT scan, radiation planning is done, and then later in the day they're hooked up to this HDR machine where multiple radioactive sources come out and temporarily treat the prostate. Everything's withdrawn back into the machine, and then often that's done again 8 or 16 hours later for 2 to 6 treatments total. So this is an option. I don't know if this is done a whole lot locally. Someone I heard anecdotally, Christ Hospital was looking at this a little bit, but I'm not involved in this, so I happened to find this picture online and just looked a little prohibitive. Prostate SBRT, meaning stereotactic body radiation therapy. So like HDR, maybe a higher dose per treatment translates in a higher chance of controlling the cancer for, again, something that's doubling a little more indolently like prostate cancer. Somebody gets 5 treatments versus 42 to 48. Well, that sounds better to do this for a week than to do this for 10 weeks. The upside compared to HDR or seeds, there's no anesthesia except a little local anesthesia when these little gold markers used to aim are put in the prostate, and all treatment is outpatient. So even though there's a word called Cyberknife, there is no knife. That's a Madison Avenue term. The radiation is aimed precisely like a knife. So what a Cyberknife is, it's a unique machine that places a linear accelerator that generates radiation on the end of a robot with multiple articulating arms for delivering the radiation. Beams are non-coplanar, and what I mean by that, I think I showed you a slide earlier where there was a CT scan in the beginning and some of the radiation came from this direction and some came from this direction and this direction. Well, the Cyberknife machine can articulate, so not only does it not go all the way through the pelvis, but it can come from above or a little bit below and divide the radiation up into 80 to 120 different directions, not even 7 or 9 as typically is done for IMRT. The uniqueness of the Cyberknife is every 15 to 30 seconds, it checks that the little fiducial markers are spot on before the machine is turned on, so it is hitting what it is supposed to hit and is not hitting the bladder or bowel. Software corrects for variables in alignment, X, Y, Z, pitch, roll, and yaw, so we are very confident if we're giving 5 high-dose treatments, we want to make sure we're hitting what needs to be hit and staying off bladder or bowel. This is the Cyberknife machine. So the radiation is emitted from this end, but this rotates, rotate here, here, and swivel around here. The radiation comes from multiple directions.
It always has a gold tracer in there?
Yes. The X-rays, which are used to aim, are great at seeing bone and air, like a chest X-ray. We've all seen, okay, I assume that's my lung and that's my heart. But soft tissue, where my spleen stops and starts and where my liver stops and starts, it's not so clear, so the machine needs a target. So it's not, the markers are in the prostate as a surrogate for aim over there.
How's it seen? What kind of...
So, great question, and thank you for bringing that up.
Repeat the question for us.
Oh, just, does everybody use gold markers for Cyberknife? If the Cyberknife machine is used to treat something in the lung, the liver, the brain, not necessarily, but the prostate, yes. So a patient is on their back, their feet are towards the machine, but these 2 devices in the ceiling take pictures from oblique angles, and they meet on the floor panel here, and that's what's used for alignment, and I'll show you a picture that may answer the question. So someone here is lying on their back, their feet are towards the machine. We make sure that the patient's fine because radiation's being emitted, no one's in the room at the same time, much like the dental hygienist always seems to scurry out when it's time to get your dental x-rays. This is a CT scan gotten before the treatment's even delivered, a week or 10 days prior. These are the little gold seeds in the man's prostate. This is your left hip, this is your right hip, you're facing that direction. And when you're on the treatment machine, the image is a little more teal, blue, green. And we sort of superimpose those markers, and if those markers are on, you need at least 3 of them to be on to correct for the pitch, roll, yaw, XYZ, treatment can be given.
How are the gold seeds put in?
They're put in like a biopsy. They are in forever. One is less sedated than a biopsy that you can drive yourself home, whereas most people tell me that's one of the hurdles, and it's great, I need someone to drive me home that day. But that being said, I haven't had it done to myself yet, so I can't tell you what degree of discomfort, hassle, pain. But I know there's an enema involved and going through the bowel and a little antibiotic and all that other stuff like a biopsy. So Cyberknife is a little newer. One of the fathers of the treatment is in the metropolitan New York area, and he helped train us. He published something in 2014 on 324 low-risk prostate cancer patients, meaning PSA under 10, Gleason 6, and 153 intermediate-risk patients. For simplicity, assume Gleason 7 and your PSA is north of 10. Followed these people for about 6 years, of which a minority were out 7 years. Defined treatment failure as PSA nadir, meaning the PSA drops after treatment. You get a low of maybe 0.7, but once you hit 2.7, hey, that treatment didn't work so good. And for the 7 years out, that'd be 84 months. So for these 123 patients that are out this far, he reports about 96% success for low-risk disease, about 90% for intermediate-risk disease. They concluded that Cyberknife success, based on a PSA staying suppressed, is durable. You got at least 7 years of good news, and that compares favorably with other radiation modalities, at least for intermediate and low-risk disease. Last on the list of things I know a little bit about is protons. Protons involve a machine called a cyclotron, generating a particle that deposits its energy sort of all at once rather than passing through and through. There's a reason the patient is in a room getting radiation by themselves, and that for photons, the beam goes through and through. It's just when it meets in the middle, that's the high dose area. The walls of our machines are about 4 feet thick of cement. But protons give and even despite that, much of the radiation, there's a minuscule, clinically insignificant amount that sort of ricochets through the patient, will not cause any nausea or hair loss, but there is a negligible amount going to other tissues in the body. That people get a little bit wigged out that if a young child has a brain tumor, a spinal tumor, and gets radiation traditionally, and they beat that, years and years later, they might get another cancer from the radiation given to cure the first. And in the world of pediatrics, that is a big driver of some of these proton machines. The cons of protons, although I think the cost has come down to about $30 million, some of these centers cost about $200 million to build. One of the issues, there's a catheter in the bowel for setup reproducibility and to avoid the bowel as best as possible. Protons are 44 treatments, not 5. Protons are particularly pricey, because even if the prices come down, the centers are still quite expensive. At least in the medical literature, there's no evidence that protons are superior. They might be as good. There might be some other benefit in terms of negligible radiation within a patient's body, but they're not necessarily 100% cure. And some commercial insurance, I'm not even sure if some of these companies still exist with the consolidation in the last 6 to 18 months, but they stopped paying for it. Medicare might cover it for prostate, I believe. But again, I don't want to misspeak, but I believe that there is definitely a center going up in the Westchester, Liberty area, I think late summer, early fall. So in conclusion, there is no one-size-fits-all for this disease. Surveillance is an option. Surgery is a great choice for some men. Radiation comes in multiple forms as described. Treatment selection, I think, is a large part based on patient preference. You know, if somebody's had two twin brothers and they did seeds and it worked great for them for 15 years, I think I would encourage them, you know, you probably share the genes with your twin brothers, you should have that too. Treatment depends on PSA, a Gleason score, gland size, at least as it relates to seeding, someone's age. Cutoff for surgery might be between 70 and 75. So that number keeps going up with better surgical techniques and anesthesia. Comorbidities, again, supplemental oxygen, pacemaker, blood thinners for prosthetic heart valves. That's going to scare away a surgeon. Insurance for Cyberknife for some people, that's become a hurdle too because it's a little newer. Some commercial insurance doesn't cover it. And that's much of what I know on radiation for prostate cancer in 40 minutes or less. Sure.
Well, my question is, do you use, or does Cincinnati have the parametric MRIs now?
For biopsies?
Yes. And treatment, and location of the cancer within the capsule?
Yes. I think more and more people are being directed to having MRIs to help find the cancer. But the cancer usually goes through the urologist first. It's quite conceivable you'd first need enough, 1 or 2 negative biopsies and still a high enough suspicion before someone says, okay, let's get an MRI. There's often something called an endorectal coil in your bottom for 45 minutes to an hour. It ratchets it up, the testing, but if it's like, look, I'm healthy, I'm functional, and my PSA is going up, I'm not getting any younger, we need to find the cancer that I think I have and you think I have, but you haven't found it through my bowel, we need to do something else. I see MRIs being used more and more.
University Hospital.
Yes.
Do you use that to locate the cancer within the?
That is used, yeah, but that's
I
more.
mean, on a sophisticated basis.
I'm more on the treating end than the finding end, but yes,
Okay.
more and more patients that I interact with are going through the university and having a fusion biopsy with an MRI, but the few I've seen, it's because they've had negative biopsies before, yet the PSA keeps going up and there's a suspicion that something's been missed repeatedly.
Huh.
Now, your statistics for high-risk patients, you only showed, I think, IMRT for that. Is that because the other procedures are not recommended for high-risk patients?
No, I guess, so there's different levels. So high risk means there's a little more suspicion that the cancer may not just be confined to the prostate based on the Gleason, the PSA. I tend to think that seeds are treating the prostate with the tightest margin, which for side effects that sounds attractive, but if there's a risk of a little cancer beyond, you'd like a little insurance. Cyberknife probably treats a little more than seeds. We can treat a little bit of the seminal vesicles, which are right above the prostate that sometimes cancers crack into, but we can't chase lymph nodes, for example, with Cyberknife. IMRT not only hits the prostate, not only hits the soft tissue around the prostate by 1/3 to 1/2 inch, but it can treat lymph nodes in the pelvic area just in case there's microscopic cancer in them that the scans aren't worried about, but scans aren't infallible, that if there's something in a lymph node the size of a BB, no CT scan's going to find that. It's only when it gets to a dime or a nickel that a radiologist is going to say, I'm worried about that lymph node. But for high risk, sometimes there's IMRT and seeds, because the IMRT kind of treats broadly, rein it in, and then the seeds would be the final punch to where you know the problem is the prostate itself.
Seeds are contraindicated because of the size of the gland, is that because
There's enough,
too many in?
you can't get enough seeds in there because the pubic bone tends to block hitting the anterior aspect of the prostate.
Can't insert it.
There are ways to position the patient intraoperatively that never say never. A lot of it depends on the urologist's comfort. But you don't want to be halfway through and say, well, good news, sir, and bad news. You got seeds, but you only got half of what we intended to do an hour and a half ago. There are ways to shrink a prostate if need be. There's hormonal treatment that sometimes somebody can get a shot of a medicine that suppresses testosterone. That shrinks the prostate maybe about 25 to 35% within 3 to 4 months on average. That medicine will introduce other side effects that might not otherwise be needed in a man with a PSA of 8 and a Gleason 6, like hot flashes in particular, maybe a little fatigue. But that should shrink the prostate, but I've cared for a couple people where they've done that for 6 months. They've had all the hot flashes, a little fatigue, and gee, the prostate didn't shrink enough. So there are averages. Somebody shrinks 50%, we'll put the seeds in. Great, I didn't shrink at all. I got all these hot flashes, now I got to figure out in the fall what I want to do next. So that is an option.
I'm not a technician like some other guys are more educated. I'm the sales department, but I've been in it 15 years now, and the old deal was surgery or radiation. And now, and you might want to explain what your group does, because you're so large and so sophisticated, but would be, let's say, urology group or UC or something versus the radiation guys. But now I understand your organization is embedded with, on some kind of basis, with the urology group. And in the same building, I guess, down there in Norwood.
Yes.
So, and explain, how does a layperson walking in the door know they're going to get, that? And the second thing is, I don't know if you saw in a paper that ProScan Imaging is now teamed up with the urology group to do the imaging that they're doing at UC. And I don't know if you're up to speed on that or not, but maybe you could. But tell us how, you used to go down the street and be them versus us, now we're together in the same bed. And what do we as lay people think of all that?
2 to 2.5 days a week, I'm in Norwood doing the Cyberknife. Years ago, I saw a gentleman who came to me and said, I heard you're an expert in prostate cancer. And I said, no, I'm not. I just see a lot of it. He said, I think that makes you an expert. I think an advantage to what I have is I am one of the 3 people that's involved in the Cyberknife program, so I can add that perspective to what somebody at UC or TriHealth cannot. I am involved in seeding cases because some men still get seeds. The urologists are a little enthralled with the Cyberknife because, at least from their perspective, the short-term urinary trouble is not nearly as bad. I think seeds, I don't know if anyone in the room has had them, and again, not everyone's side effects are the same, but again, for many months after, there can be burning, getting up more, honey, get out of the restroom, I gotta go again. That can go on for 3 to 8 months plus, not always. Whereas with Cyberknife, within 1 to 3 weeks, most people are saying, yeah, I had to squeeze harder to empty and I got up a little more, but I'm fine again. So the side effect profile seems to be a little more desirous. There's no anesthesia. Gland size is not a limit for Cyberknife. So there's a lot of excitement. Again, the caveat I would say though, and maybe this is why Humana and Anthem are a little more rigorous, there's not a lot of 10-year data out there. There are a handful of there's a little data on high-risk disease treated with the Cyberknife, but just because 40 people did it, should that mean Humana and Anthem cover it for everybody? Don't know. Again, I think if you do patient selection, if your PSA is 80 and you have Gleason 8 or 9 in 11 out of 12 cores, I don't think Cyberknife's probably your best bet. Now, if you've got one needle of 8, your PSA 6, and all the other needles didn't show cancer, probably in the future that is reasonable. I'm a little cynical by nature. A urologist could take out the prostate of a 95-year-old with Gleason 8 cancer. They would never leave the hospital and be on a ventilator 6 weeks. Insurance would pay for that. But they wouldn't let a 70-year-old get Cyberknife for 1 core of 8 as an outpatient. I don't quite get that. Because, of course, the 95-year-old, their kids would say, Dad, you're not doing that. But that's just where we are now. I moved here about 20 years ago. Seeds were in their infancy. And I perceive in retrospect, seeds were put in men initially, probably in their late 60s, early 70s. Might die of something else, but I don't want to assume wrong. Let's put in seeds since it's newer and see how it goes. Somebody turned the clock ahead a decade and said, wow, that worked well, and you were only asleep 60 minutes, and you didn't leak, and you didn't even have stitches, great, let's offer that to 50 and 60-year-olds now. Cyberknife will probably be that way in the future, it's just not quite there yet. I know Medicare is a little more liberal, United's more liberal, Cigna, but Humana and Anthem are a little more challenging. But to highlight that, my sister went into healthcare after getting an MBA, and they said, healthcare, you could do Wall Street, you could do whatever you want. Why do you want to do healthcare? And she said, I want to be my brother's boss. That highlights some of the latest and greatest in medicine. But
Well, I was trying, I don't want to take up the whole night here, but the surgeon gets paid to cut and the radiologist gets paid to radiate. Now they're down to the urology group, and we're the layperson. How do you split up the money? I mean, the surgeon wants to cut the radiation, and we're in the middle. We hear this all the time in these meetings. What am I supposed to do? Who's interested? No.
I think the urology group has done a really good job of having people see multiple specialists.
Right.
There is no medical oncologist involved in the beginning because their treatment's more further down the road if needed. I agree. One of the people who trained me said, you go to a hat store, what do you get? No, a hat. Even if somebody was 52 and said, cut it out, surgery, they don't do that for at least 6 to 8 weeks after a biopsy before that area is re-traumatized. So you have a built-in period to explore and contemplate. You can't take health care back. If you're not happy a month after surgery, there is no Gorilla Glue and duct tape that's putting it back in. Everybody should at least ponder for 6 to 8 weeks, but the problem becomes everybody at work will tell you, well, my dad did that, my brother did that, and my sister's boyfriend did that. You have to factor in, well, of course your brother-in-law did surgery, they were 50. I'm 80, I ain't gonna have surgery. I mean, you have to sort of base things on your own station in life, your own priorities or preferences. I guess one of the negatives to mention about radiation, to be frank, if one pursues radiation and down the road the PSA starts going up, more radiation is not commonly done. The bladder and the bowel typically don't want to get hit again. Whereas if you do surgery, so if you do surgery on that patient, because hey, I'm 55, I didn't make a good choice 4 years ago, surgery is associated with a high risk of leaking. Wearing it depends every day the rest of your life, if you're in your mid-50s, is not going to be very exciting. So if you do surgery first, and I don't even have a prostate, and my PSA is going from 0.1 to 0.12 to 0.14, and we got a trend here, and I don't even have a prostate, aiming radiation down below, presuming that's where the microscopic cancer has reactivated low in the pelvic area of the prostate bed, that is not nearly associated with as much leaking, so the backup plan is better. Now, as I tell people, if your PSA goes up when you're 98, that might be interesting. I'm not sure that needs to be treated. If you're 74, but since your treatment 6 years ago, you've been struck by lightning twice and have had 6 strokes, I'm not sure that's an issue either. I know, I'm just telling you how people think. If your PSA is going up 0.2 a year and you're thinking, gee, I'll be 90 before it hits 8 like it was in 2017, well, I'm not sure that needs to be treated. The backup plan after radiation, if somebody is young and functional, and I'm losing sleep over this because something didn't go right the first time and my PSA is doing this, like doubling in 6 months or it's soon to be 10, prostate cancer is fueled by testosterone. The backup plan after radiation is often hormonal treatment. That is not a cure, but usually works for at least a few to several years. That's at least a slowdown, and again, objectively thinking, you know, hey, man, I'm 76, maybe that's all I need at this point. If the cancer grows through that, while nobody wants any of this, there's newer pills on the market that probably cost thousands a month. There's radioactive medicine given once a month for 6 months that targets the cancer in the bone. There's chemotherapy. There's this immune drug that's prohibitively expensive called Provenge. There are a lot of things to throw at this. Traditional chemotherapy with all the weakness, fatigue, hair loss. So there's tons of things to throw at this disease. But to go back to your question, right, the best time to treat any cancer correctly, whatever that means, is the diagnosis, not recurrence after recurrence after recurrence.
There wouldn't be any problem if you did do
radiation, say Cyberknife, and it didn't work. You could go back and have surgery, couldn't you?
There's, any form of radiation will cause a little rind of scar tissue to form around the prostate. And
Okay.
it's a little harder for the surgeon to hook the pipes up. Leaking is supposedly 50-50. Now, there's probably some correlation to, well, if you do that procedure to somebody 75 versus 55, oh, by the way, I'm also a diabetic and I have high blood pressure. My blood vessels aren't as good, so I'm not going to heal as good. That has to go into the equation.
Okay.
It's been done. I wouldn't want to be the first patient of a urologist to have attempted that, but if someone's like, yeah, I do that once a quarter, I try not to do it, but I've done it, that is an option. But
Okay.
the backup plan, again, so how does a patient decide? I think a little bit is here. If somebody's thinking, gee, I'm young, I need every option available to me, several siblings have this. Sometimes surgery first at least gives you the option for radiation as a mop-up just in case things reactivate. Whereas if you choose radiation first, which is a good option, we saw Dr. Katz's numbers, 90 to 96% of the time it should work. But not everybody is the 96 or the 90.
I think today is more to contain it rather than surgery, because years ago, 8 years ago, it was mostly surgery taken out. And now with all the new drugs and all the radiation and all that stuff, the thinking is to leave it in because you have less other problems and treat it with these new drugs, because some of these things have only been on the market a few years. And I've had some of these, as you well know. I did the immunotherapy last year, the ProVen, and for information in the room, I just finished 3 weeks ago the radium-223 treatment, which was administered by Dr. Grass. So that was a 6-month process, and it's a radioactive isotope. Now, correct me if I'm wrong here. It has a cumulative effect. First few times you don't notice any side effects, and you may get a little nauseous, you may get a little tired, lose some appetite. Not everybody makes it 2 to 6 months. I actually gave thought after the 5th month to cutting it off, but I thought, well, I've been through this much, I'll go one more. After about a week, it kind of hits you, and lasts for about a week, a little bit more, and then you start feeling normal again. But mine have metastasized to the bones, and when they discovered I had a PSA of 58, and Gleason of 8 to 10 in all the cores. So I get injections of Firmagon, Exgeva, then I take Standy, and then I get, like I said, I just finished the radium for the bones, and we hope that takes care of that problem. So the thinking seems to be to contain it and treat it and control it.
More like living with diabetes, living with a condition, as opposed to cutting it out and,
And that's what the future is with a lot of these genetic tests and trying to predict, you don't need treatment because your genes say this is going to be slow growing for 15 years and you're in your late 70s. But
it seems like the Veterans Administration, I have a number of clients, I'm a tax accountant, and an awful lot of my clients were diagnosed 2005 through 2007, went to the VA, had a radical prostatectomy, and now they're dying. Basically, it's like the VA simply cut it out, said, you're fine now, go home, very little follow-up. And there seems to be an entire cohort of men who are doomed because of that. It seems like a lot of the newer treatments, a lot of these things, I don't know if they're more, you want to say they're more effective, but they're focused on a longer length of time, for these men to live,
I think radiation has come a long way with technology. I think side effects that people had from radiation administered 15 to 20 years ago are, well, they still turn out, but they're certainly real. But I tell people, your car has gotten better than 15 or 20 years ago as well. You've got remote start and satellite radio and navigation, and maybe 15 years ago you're just hoping the car would turn on. Our machines have gotten better. Surgery has side effects, but it's still a good option. Robotic surgery is easier. You're home the next day than 4 to 5 days in the hospital like a decade or more ago. So, you know, again, double back to one's preference. Person who trained me, I said, how does a man decide? And he pointed right here. I said, Kevin, I just finished medical school. I could have sworn it's down there. I said, no, some people say cut it out. That fixed my dad's, that cured my wife's breast cancer, heal with steel, surgery. I've seen men that say, you know, I'm an executive with 400 employees. If I don't show up for work because I'm recovering, the company folds. Well, I don't think surgery's going to go so well. Other people don't want to be radioactive with seeds. You know, their daughter's a single mom, maternity leave ends Monday, and I got to change diapers again at 78. Who would have thought? Other people can't come for 9 weeks because I got a job from Louisville to Dayton. You got to be kidding me. I can't be in the same place every day for 10 weeks. That's absurd. Some people think Cyberknife is too new. I mean, I saw somebody whose insurance covered it, and he's like, that's great, but maybe Anthem and Humana are smarter than you guys. And there's a reason they're not covering it, because maybe in a decade there's going to be all these complications that no one's contemplated or experienced yet. It depends on the mind.
Exactly right.
It really does. So it's the recovery period, it's the side effects. I mean, to give surgery a plug, if somebody has radiation, the success is dictated by the PSA, which often goes down over 9 to 24 months. Down, 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 because the whole prostate is going to be scarred down very, very slowly. With that, though, sexual function only goes in one direction, and that's south, because the patient's also getting older. But for someone who has surgery, and they have a nerve-sparing surgery, there is no sexual activity 6 weeks later or 2 months later, but with surgery, time heals. Like, people have had a stroke, and they say, give it a year, you'll recover. So that could be an issue, that yeah, I'll give it up in the short term, but I'm more likely to regain it, whereas with radiation, things are only going in one direction, and that's down. Shouldn't use that gesture for that activity, but... Yes?
Yeah, since you're talking about side effects, you presented a slide on the statistics of side effects, but it went by pretty fast.
Got
Can you go back to that?
Yeah,
It was kind of hard to
for,
read.
in terms of blood in the urine and bowels and that stuff? That one?
No, back and forth. Yeah, that one, I think.
So,
What are those 4 charts showing there? I can't read.
okay, laser pointer, eyeglasses, all right, we're ready. So radiation side effects come in 2 forms. There's the acute ones that you get during treatment and maybe for several weeks to a few months after. And once you're through that period, then you get something called late effects, which everybody does not get by any means, but that's from the scar tissue that forms month by month or season by season. So some people, as an after effect of treatment, even years later, can have a little blood in the urine. So this is what's called late actuarial GU toxicity. Grade 2 is here. I think we looked at the table on the next slide, beanie, weenie, miny, mo. So within a 6-year period of treatment, if you got a little bit of both, because that's both seeds and radiation, there might be a 20% chance, again, genitourinary bladder, of getting up a little bit more than baseline, or occasionally noticing some blood in the urine. So that's a long-term side effect of that. In terms of GI, because even though we aim precisely to put those seeds in the prostate, everything's kind of jam-packed down there. Both carry about a, IMRT the whole way or IMRT and seeds. There might be about a 3% chance, if this is grade 3, GI. GI grade 3, you still need some antidiarrheal medicine years later. You need a little blood transfusion every now and then, or even because there's so much bleeding, pursuing something called hyperbaric oxygen. Again, that's 2 to 3% of people, 1% too, but it's not zero.
What about secondary cancers, other long-term effects? What about the impact on the bone marrow, pelvic region, and your immune system?
Radiation does not affect the immune system like chemotherapy, which goes everywhere, but most bone marrow products are made in the pelvis. There is probably a small, albeit negligible, reduction in blood counts, and some people say, well, that's part of the fatigue, that I became a little bit anemic during treatment. In terms of secondary cancers, I know that that's definitely reported, but the way I reassure people, sunburn today is not skin cancer in 2 weeks, but maybe 15 years from now, I should have worn a hat when I was playing golf. Radiation when you're 70 to your prostate, it typically takes at least a decade for that small increased risk to manifest. If somebody's particularly young, like going through this in their 50s, early 60s, and gee, doc, I intend to be here 30 years, you know, that could go into the decision making. In somebody older, I mean, to be frank, I don't even mention that. Again, the way I would spin it, if you were going to buy life insurance at age 72, the actuary might say there's a 5 in 1,000 chance, even walking out the door with no treatment, you'll have rectal cancer or bladder cancer in the next decade. Maybe because of the radiation, it's 8 in 1,000. The leading story on the newspaper would say 60% increase from radiation for men with prostate cancer, but it ain't particularly likely. But the other corollary to that, though, is if you have been treated and years later you see a little blood in the urine or bowels, please don't assume it was an after effect of treatment. Get it checked out. That I would hate to have somebody say, oh, I assumed it was from the radiation, and gee, that was the first sign of my colon cancer, and if I only acted on it, I wouldn't have this problem. And again, there's different magnitudes of bleeding. If there's a little blood on the toilet tissue once every 10 months, and you're thinking, I bled more picking a cuticle yesterday, have it checked out, but that's probably not very exciting. If it's, gee, I'm not sure I should go have brunch with my friends, look at the toilet, yeah, that would need to be fixed. That would be 1 in 1,000 for bad complications like that, but that is not impossible from radiation for prostate cancer.
This is somewhat of a follow-up to Tom's question. Presumably, one of the advantages of going to a research hospital is that you see that there's a whole team of people looking at you, sitting around a table talking about your condition. In a group like the urology group, you mentioned a lot of specialties, etc. As a patient, do you get that same kind of treatment that you would at a research hospital with a team looking at, or is it just your particular oncologist or radiation oncologist that's...
There's dialogue between urologist and radiation doctor, but we also ask you to participate in what you want done. There is a tumor board once a month where we present challenging cases. You know, what should I do with this? Their PSA keeps going up and they're 55 and they have this treatment and no buy-in. But not every patient diagnosed is discussed one-on-one. That would be probably a kind of a falsehood. No, I mean, one of my observations when I first started practice was how little direct dialogue occurs doctor to doctor. You know, that doctor's just taking care of my left ankle, he doesn't talk to the guy taking care of my right ankle. Really? Yeah, you just...
So, if I'm a patient and my oncologist happens to be a surgeon, but he's in a group practice, is he likely to bounce ideas off the radiation specialty?
Maybe not. I think that it's empowering to say, that's great, doc, but are there any other ways we can do this without surgery? Because I'm not quite sure that's what I want at my station in life. And if they say, no, it's the only one, okay, let me talk to my wife and I'll be back. No, I mean, there are options. There is no emergency prostate cancer that needs to be removed before the end of the day, or good luck seeing the sun come up tomorrow. This is, I try to reassure people I see maybe too much and say, when I'm seeing you and you're diagnosed with low risk or intermediate risk disease, you're contemplating treatment, so 7 or 8 or 9 years from now, the words prostate cancer aren't in your file as an active problem. It's not, boy, I better do this by Memorial Day, or I'm in deep doo-doo by Thanksgiving. This is not lung cancer or pancreatic cancer, that you better start doing something or you'll be regretting that soon.
I noticed in your results with the Cyberknife, you were using 3-3 type Gleason and PSA of under 10, but...
Not, and intermediate risk.
Or intermediate, well, but that's also the same kind of numbers that people would look at active surveillance. I mean, we've had the Snuffy Myers gave us a study of surgery versus active surveillance, and the common group, more people died, had higher mortality with the surgery than the active surveillance. My question to you is, I know you've got a very expensive knife down at the urology group that you're obviously trying to amortize, but how much effort is made by the urologists today to sit down and talk about active surveillance, promote it, deal with it? I mean, you're not going to get a big cut because you're not cutting, but as a doctor, is there a protocol that you guys look at?
The urology group does have a protocol of if you choose surveillance, I think that means another PSA in 6 months and another biopsy in a year.
Yeah, okay.
Surveillance, I think, is a great option for somebody a little older. If I see somebody 53, I'm like, well, you're waiting, but you're not going to be going anywhere soon like somebody 79. Again, not trying to offend anybody in the room.
Right.
But
You just
just
hit
the
me.
reality of life. But again, it's how many cores are positive, that even if you got Gleason 6 and your
Right.
PSA is 4.1, if that's in 4 or 5 or 6 cores, yeah, there might be a little more cancer down there than you just want to
Right.
watch.
But do you watch it with the parametric MRI or those types of devices that are now being widely used in the business, I don't call it a business, in the
It's
profession?
a business.
I would say getting there.
You're getting there.
But, you know, I think I heard a mammogram was once, I don't know, $40 to $100. I don't think a prostate MRI is $40 to $100. So there's got to be some nomogram of, okay, we're going to put you on that pathway, but we know you got it, you got Gleason 7, 8, what do you need an MRI for? You need to get this treated.
Well, no, I'm thinking more of active surveillance. They've got something, but this is a way to keep an eye on it, I guess.
But then people put a lot of weight on a PSA, and maybe one PSA shouldn't be the be-all, the end-all.
I agree.
So that's why they repeat the biopsy, just to make sure something that's been dwelling for a year, 3 or 4, that 2 cores of 6 doesn't turn into 5 cores of 7. And we assumed you'd be in a nursing home by now, and sir, you just had bypass and are looking 10 years older than your stated age. This needs to be treated. Don't just do surveillance with the PSA and think, well, if it's staying 6 to 6.5, I've got no issues forever. That's
That's why I want the
probable,
MRI.
but not
Not doing
infallible.
it,
Back in the day when I got mine, I was the understanding the only biopsy that Medicare would pay for was the blind one. They wouldn't pay for one that was guided. Where I went, they called that the $1,000 biopsy, where they took a picture and then do they do that today, you know?
Medicare does. Yes. I can guarantee that.
Medicare,
Medicare pays for guided.
MRI guided or?
Guided biopsy, yes.
Yeah, okay.
Yeah, there's probably some form that the urologist has to fill out ahead of time saying, you know, come on, why do you want to get this? Because I've already had to
I
buy
believe,
it.
from what I went through with my urologist, I believe it is the case that he had to exaggerate a little bit about my condition in order to get the inclusion for the MRI.
But it's pretty, there's a reason technology and MRIs are being used. Again, this is so much different than breast cancer, where there is a spot that's seen on an MRI and ultrasound and a mammogram. I think that's where we should biopsy. Just because the PSA creeps up, they sample the whole gland, and to an extent, things that are more distal or more anterior from the bowel, those are ones that sometimes get missed.
Okay, now, so I had a 7 and an 8, okay? Could I have had some 6 in there? Could I have had some 9 in there, or?
You don't know till it's removed and looked
To
at.
find it, right? So it's possible to have
All sorts
all
of
Gleason
patterns. Yes,
grades in there.
yes, yes. That the cancers are a little less uniform, and the higher number usually I don't know, horrible analogy, if you get pulled over for speeding, it's like, yeah, but I was going 55 for the last hour, but yeah, but for the last 3 minutes, you're going 70. The higher number dictates,
Oh, yeah, yeah.
but it's frustrating because, you know, 1% of one needle has an 8, everything else is a 6, and now you're not gonna do seeds or Cyberknife? Yeah, why not? I don't know. It's just there's,
But they shouldn't take an average, they should take the highest number.
right, that's, right,
That's the fastest.
That'd be the most logical thing to do.
right.
If there's 1 8, there's probably more 8s.
And that's why you assume the worst case. And worst, yes, don't undertreat a cancer,
Yeah.
right?
You said hormone therapy works for a while. Why does it only work for a while? Is the gland figuring out a way to get around the need for the testosterone?
I think the cancer figures out that despite being stimulated by decades of testosterone as we were in our 20s, 30s, 40s, 50s, one little cancer cell figures out, I don't need the fertilizer anymore, I can grow on my own autonomously, and that 1 becomes 2, and the 4 becomes 8, and the 8's 16, and
The
your
longer you're
PSA.
on hormonal therapy, the more chance you are that it's going to stop working.
There's some that argue that's one of the advantages of doing it intermittently, that you still challenge the cancer periodically, and it goes a while without seeing on-off might reduce a little less resistance. Years ago, tamoxifen for breast cancer was given for 10 years, and someone said, well, after 10 years, it fuels the cancer, not fights it. So,
Ask you about finasteride.
finasteride is supposed to shrink the prostate, drops the PSA, helps you pee a little better, but some people say that it might promote ever so slightly a little more aggressive prostate cancer, the kind that wants to grow without hormonal treatment.
Speaking of hormonal treatment, is it part of your standard procedure to use hormonal therapy as an adjuvant to radiation? In other words, using both?
Depending on how advanced the cancer is, yes.
But it's localized, let's say it's at least a 7 or 8, or under which circumstances would you recommend hormone plus radiation?
There's a ton of controversy about hormones, but as I tell people, the only way surgery and radiation are going to cure it forever is if 100.000% of what you've got is in the crosshairs and isn't going anywhere else. Hormonal therapy can be a little bit of a global head-to-toe protection that in case there's one little microscopic cell, because I have Gleason 7, 8, 9, 10, that gives you a little bit more systemic protection, albeit with some more side effects. So I think if you're 4.3, not 3.4, if the PSA's high teens, there's a lump, there's a little more cancer that needs to perhaps be eradicated.
Well, isn't the theory that hormone therapy makes the tumor more susceptible to radiation therapy? In other words, improves the odds that the radiation will in fact cause the cells to die.
But radiation also keeps getting ratcheted up with dose, that some of those, a lot of the hormone studies came out, people only got 35 treatments. Well, now you're getting 44, so you're not really comparing apples and apples. There is still a benefit. Hormones are not for everybody. There's supposedly a small increased risk of heart attacks if you give a man that drug. There's people who gain a ton of weight, or their triglycerides and blood sugar gets all out of whack. It just unfortunately highlights nothing simple or straightforward. That I sometimes have people help me make the decision that if you want to do everything by the book because you've got a teenager still living under your household and you need to see them get married, you should do hormones and never say, gee, if only. If it's, oh gosh, doc, that sounds horrible, I'm 74, I don't want that. Well, okay, let's be optimists and hope that the radiation, even IMRT to even for high-risk disease, PSA north of 20, high risk. Mind you, some of these people got hormones, but there's still a reasonable chance of controlling that. Maybe that number doesn't, again, their median follow-up's 5 years. I'm not sure where they're getting all this. There might be only one patient out that far, but right. I mean, I see men with at least an 8, 9, 10 that had surgery, and sometimes it's all in the prostate, and the medical books would have said you wouldn't get it all with the scalpel, but it did. How about it? So it, you never know. Yes.
What are your thoughts on cryo treatment?
Not done particularly commonly in Cincinnati as initial treatment. See, it's done anecdotally if the radiation doesn't work and you have some scans and think it's only in the prostate and nowhere else. That is done to freeze part of the prostate, and what you assume is 100% of the recurrent disease. There is somebody in Pittsburgh that proposes it out of the gate like surgery or seeds or radiation, not done particularly commonly in this community.
One more question.
Sure.
The news says that Tim Hendrick died of prostate cancer. He had surgery 8 years ago. He was 55 when he died. Now, one of the questions I always have, do you really die of prostate cancer, or do you die of it spreading to other places? Because that seems like an awful short period that you wouldn't have.
No, I think it's spread, and I'm guessing that caused some degree of pain, and I'm on more pain medicine, and I'm getting a little weaker, and now I'm getting blood clots and bed sores and infections and UTIs because I'm not breathing deeply because I'm in bed when I'm not on TV.
Likely spread over.
Yeah, that part of my training, I don't mean to go back to this, but I worked with somebody who gave chemotherapy for a month. He said, well, after someone has their breast removed for breast cancer, they should always do chemotherapy first instead of radiation, even if the cancer is advanced. And I was like, well, why? That's not what I do. I do radiation. And he said, if I could guarantee a patient for 75 years nothing would spread outside this area, it would never threaten your life. It might cause a lump, it might bleed, it might hurt, but it's when it goes to the brain, the liver, the lungs that you're on borrowed time. So I'm guessing, I don't know enough, I don't know anything about Tim Hendrick's disease, but I'm thinking if something hit him in his late 40s that normally most men are faced with at a more advanced age, that gene's somewhere along the line. I mean, just like somebody with breast cancer at a young age, you know, gee, I thought, you know, I told somebody once 27 with breast cancer, we have a 90% chance of cure, and she's like, great, I'll be 32. That's not good enough. You know, you tell somebody 82, you got a 90% chance of, great, I'm going to wake up tomorrow. It's
But
a
when they say
strange,
they die of prostate cancer, what they're really saying
it
is
spread
dying
somewhere
of
else.
the spread, where it started, not of prostate itself,
right,
right?
yes.
If nobody dies of prostate cancer by itself. Is that true?
I will share one exceedingly funny story with you. I've got two,
Funny about that.
well, no. I've got two boys, and they used to compete with each other who could ask Dad a more difficult question. And I told somebody years ago, I've seen a couple people with penile cancer. Very, very, very rare. I went to examine this gentleman, and I, for all the world, thought there'd be a bag for urine somewhere. And lo and behold, they had a little orifice below the scrotum and urinated just like a woman sitting down. And I told my kids how fascinated I was by this. I had never fathomed that in all my medical training. Well, my one son said, penile cancer, how do you die of that? And his little brother, who lost his grandmother to lung cancer, said, how do you smoke through your penis? That this little mind of a 6-year-old boy was. So many cancers you don't die of where it started. It's when it goes to other vital organs that then just starts to really affect.
Right. Not in the death.
Yeah, right. If it goes to your liver, you don't clear some of the toxins in your blood. You turn jaundice. You're weak. Eating's the last priority. You need pain medicine to control the miserable pain that you can't even get out of bed for. It's tragic, but it's reality.
How effective is the Provenge treatment for keeping it from shredding?
I think Provenge helps, as do pills like Xtandi, Xgeva. There is a spectrum. Sometimes it's only seasons and months. Sometimes it's years. It's not.
Not good at all.
No, and I hope, I hope it wasn't conveyed that, but the goal is to make it like diabetes, that if we can keep you going long enough and, you know, you have a heart attack in 6 years, great, I did my job. No, I mean, I'm not trying to be wise, but it's the harsh reality of everything helps. And again, I finished training in 2000, there are things on the market that did not exist 15 years ago. There was no ProVeg, there was no Zofigo, there was no Xtandi, there was none of this stuff. Things get better and better. Mind you, the new stuff ain't cheap. You know, there was a drug for kidney cancer, I think, that helped people live 6 weeks longer, that England said, I don't think so. 50 grand for 6 weeks? Maybe not. But if that was you, or you're 52, or, you know, I understand if you're 98, that's probably a good decision for the population as a whole. But if it's you, you know, who do I write the check to? It's a stinky part of business that despite what you do, and it's hoped, it is known the more of a beating you can take, the better you'll do. That if you're young and motivated and tolerate the side effects, you're going to do better than somebody who says, hey, after one radiation treatment, I'm not sure I can handle this. That's kind of hard to beat back to cancer if you're not able to handle what we want to do with it.
So with all the research going on, you come back in 10 years, is your story going to be a lot different?
Probably treating a lot less men. Probably a lot better medicines to knock it out longer. Yes. Yeah.
And as you grow it.
Yeah, or at least be able to figure out you need treatment, you don't, you don't, you don't, you do, you do. And yes, that will be further along.
Yeah, two questions. One, on the option of combination therapy of seeds and external beam radiation, your slide implied beam radiation followed by seeds. Do you think that's preferable to seeds followed by beam radiation?
Yes and no. One of the advantages to seeds first is if there's a little cold spot where, son of a gun, the seeds didn't go exactly where we want, we can make that up with the beam. One of the issues is if you have seeds first and you're having a lot of urinary trouble, it's kind of hard to convince you to move into phase 2. That G-Doc come up 5 times a night and it stinks. I don't want to do what you planned. That in this community, I have definitely seen beam first. 25 to 28 treatments typically will make you a little tired, the bowel's a little soft, maybe a little minimal burn, get out more, but not, oh my goodness, what have I done? None of that from 25. Again, bad analogy, 2 hours at the beach, you'll get a little color, 8 hours, you might think, gee, I should have worn a hat and gone in about 4 hours ago. And the more you pursue, the more cumulative the side effects are, whether that be chemotherapy, whether that be radiation. You're not going to be tired after 1 week of radiation, but let's talk in 6 or 8 weeks.
What about the possibility of you have the seeds first followed by the external beam radiation? The seeds are still giving off radiation. What about the possibility of the synergistic relationship effect between the seeds and the external radiation on top?
It's done, no doubt, but I don't commonly see that as the sequence.
The other question I had was about PSA balance. If you could discuss that for a minute.
The literature suggests about 30% of men, particularly those who have seeds or SBRT or Cyberknife, 8 to 18 months after treatment, the number's falling, everything's great. On occasion, 30% of men will get a little blip that may last a reading or two and makes you think, gee, maybe I should have had surgery or something else because the number's doing that, not that. That's not well understood, but that can happen, and it just sort of goes back to one PSA. Don't put tremendous stock on that. It's trends. One of my ex-partners said one robin doesn't make it spring. Good point. Then if you got 3 going up in 10 months, yeah, that might raise the ire for a repeat biopsy or just some scans to make sure it's nowhere else. Again, In a man who has radiation for prostate cancer, often we want the PSA to go super duper low, maybe under 1. But that doesn't mean for a decade you're going to get 0.23, 0.23, 0.23, 0.23. It's going to go to 0.35 and you're thinking, oh gosh, it's going up, and the next one will be 0.18 and you'll think, gee, I've never been that low. So, trends. Sometimes the PSA just moves ever so slightly like a seismic needle. But yeah, some people within a year of radiation, the number can double, triple, and it's like, what in the world? And then plummet again. That's the bounce. Some people say it correlates to men that somehow still have sexual function. Not sure.
Yeah, I was kind of told that mine has cracked up considerably, but I was told mine can go all over the place because of the extending and the fetus.
The problem, not the problem, one of the uncertainties of Provenge and Xofigo is the PSA doesn't always correlate to the treatment given, and you need a bone scan, and if there used to be lesions that look this aggressive and they've calmed down, you're doing okay. Some people would say as the cancer is being killed off, the PSA is leaching into your system a little more, and that can make the number go up.
I talked to a fellow at the Norwood facility, an older guy, and his PSA, he said it was 160, and it had been that way, 160, and it had been there for a while. And he was, for his age, he seemed to be getting around pretty good.
170.
Like 70.
There is,
It's kind of like, I don't know, it's kind of like just a number. I used to put a lot of stock in it, because they think, and now it's like, well,
I would
maybe
say
it's just the side effect of all the treatment we got.
trends over 8 to 12 months, I think, are more revealing than one number. But mind you, if you don't have a prostate, and this was all unfolding in the last 6 to 10 months, if you got a reading or two going up, that's a little strange. I shouldn't have that.
I'm pretty new to this problem. I was just diagnosed a month ago, so I'm still trying to figure a lot of stuff out. What I'm sort of getting here is that no matter what you choose, you're going to have to check this for the rest of your life, kind of. If you do not remove the prostate, and let's say 6 years down the road, PSA starts going up, do we, which I'm fine with it, would we do biopsies again, bone scan again, CT scans again, just to see, wait a minute, something got away from us here, and it is going into the bones, and it did. Is that something that's common? You just kind of check this for all time with biopsies and scans, not just PSA.
Yeah, let me try to answer that question a little differently. If somebody has their prostate removed robotically,
Yeah.
you're asleep 2.5 to 4 hours. Amazingly, I went home the next day. I got out of that, depends, in 4 to 6 weeks. They don't check the PSA for about 6 weeks.
Okay.
That even if the number is awesome, there is nobody who signed up for that procedure for 6 weeks of good news, but hopefully 6 decades. That anything that we talk about in this room, you don't want the first you're not out of the woods. You need to be monitored just because you got treatment and it's supposed to work and it is working, and look at that 6 or 36 months of PSAs or even 5 or 7 years. As long as you're young and active, you should be monitored.
With the PSA going up, would you then jump to the next step, another biopsy, another bone scan? Would you do
Yeah,
that?
if you defer treatment for 6 to 12 months, another biopsy is done, and if you defer after that, another biopsy and PSA in a year, yes.
If you don't defer, you get radiation, then you think you're okay, and everything goes down, and then it starts to go up.
Yes, you're going to get some scans to see if it's
Okay,
in
good.
this area and somehow survived, or, oh my gosh, it moved on to somewhere else.
That's what I'm thinking.
But any prostate cancer anywhere in one's body is going to be ascertained from a needle in the arm.
Okay.
That if your so even though it's measuring something in the prostate, if it's now spread, it still can be quantified through a needle stick here.
Okay, that makes
And
sense.
if your PSA a decade after surgery is still 0.1, then pretty not likely to be active
Gotcha.
prostate cancer.
I understand.
But if it's 10, yeah, there's something going on somewhere.
All right.